Chronic pain can last for years and range from mild to severe on any given day. While past injuries or damage can cause chronic pain, sometimes there's no apparent cause. Localized pain exists in one part of your body, and a localized infection is also restricted to one area. In other words, it hasn't spread to other places within the body. Pain is most often classified by the kind of damage that it causes, its etiology. The two main categories are pain caused by tissue damage, also called nociceptive pain, and pain caused by nerve damage, also called neuropathic pain. A third category is psychogenic pain, which is pain that is affected by psychological factors. Pain can be difficult to assess because patients can have difficulty describing and localizing pain, as the pain may be referred pain. For instance, if someone has had surgery or has a broken bone, it may be easy to determine the cause due to the fact we can see that source, right, on an x-ray. However, many people experience pain from disease or from illness, and we cannot see these areas on any type of x-rays or exams. A patient's description of the pain may not match the actual cause of pain either, right? Such as many people experiencing gallbladder pain feel it in their back between their shoulder blades or in their right shoulder. This is called referred pain. This pain may be referred to a different area than it is innerved by the same spinal segment, right? Innervated. Nociceptive pain is the most common type of pain. It's caused by stimulation of nociceptors, which are pain receptors for tissue injury. You have nociceptors throughout your body, especially in your skin and internal organs. When they're stimulated by potential harm, such as a cut or other injury, they send electrical signals to your brain, causing you to feel the pain. Visceral pain results from injuries or damage to your internal organs. You can feel it in the trunk area of your body, which includes your chest, abdomen, and pelvis. It's often hard to pinpoint the exact location of visceral pain. Visceral pain is often described as pressure, aching, squeezing, or cramping. Somatic pain results from stimulation of the pain receptors in your tissues rather than your internal organs. This includes your skin, muscles, joints, connective tissues, and bones. It's often easier to pinpoint the location of somatic pain rather than visceral pain. Somatic pain usually feels like a constant aching or gnawing sensation. Cutaneous pain or superficial pain usually involves the skin or subcutaneous tissue. Neuropathic pain results from damage to or dysfunction of your nervous system. This results in damaged or dysfunctional nerves misfiring pain signals. This pain seems to come out of nowhere rather than in response to a specific injury. Neuropathic pain is described as burning, freezing, numbness, tingling, and or shooting pains. Physical pain has a defined source from an illness, injury, or disease, but psychogenic pain can cause pain without a physical source or make pre-existing pain increase or last longer. It occurs when your pain is related to underlying psychological, emotional, or behavioral factors. Psychogenic pain can be felt all over the body with varying intensity, though it's most commonly presents as a headache, a muscle ache, abdominal pain, or even back pain. Transduction is the activation of pain receptors. It involves conversion of painful stimuli into electrical impulses that travel from the periphery to the spinal cord at the dorsal horn. Transmission is the process of pain sensation from the site of the injury or inflammation are introduced and conducted along pathways to the spinal cord and then on to the higher centers. The perception of pain involves the sensory process that occurs when a stimulus for the pain is present. It includes the person's interpretation of the pain. Pain is a very personal experience that varies from person to person. What feels very painful to one person may only feel like mild pain to another. And other factors such as your emotional state and overall physical health can play a very big role in how you feel about the pain you're having. The process by which the sensation of pain is inhibited or modified is referred to as modulation. The sensation of pain appears to be regulated or modified by substances called neuromodulators. These neuromodulators are indigenous opioid compounds, meaning they are naturally present morphine-like chemical regulators in the spinal cord and brain. They appear to have analgesic activity and alter the perceptions of a person's pain. Pain stimulators such as bradykinin and prostaglandins and substance P all work together in the pain process. These mediators are released upon tissue injury and are important mediators of inflammation and pain. The gate control theory is a particular model and practical to explain the concept of pain. The way in which we experience pain is very complex. All sorts of factors influence our experience, including our thoughts and feelings. For example, even though a person is in pain, they are only dimly aware of it. This can happen, for example, when a person is really engrossed or distracted by something interesting or having to face a situation which demands a lot of their attention. On the other hand, some situations makes one more aware or focused on how much pain they can feel. The more you think about your pain, the worse it will feel. In the spinal cord, imagine a series of gates into which messages about pain arrive from all over the body. These gates can sometimes be much more open than at other times. This is important because it is through these gates that messages from the body pass towards into your brain. If the gates are more open, then a lot of pain messages pass through to the brain and the person is likely to experience a high level of pain. If the gates are more closed, then fewer messages get through and the person is likely to experience less pain. Things that can make the gate more open are stress, tension, your emotional status at the time plays a big role in how a person perceives pain. Mental factors, staying focused on the pain itself, lack of activity. So sitting in a hospital room all day looking at the four walls can cause someone to focus more on their pain and definitely can increase their pain level. Factors that can contribute to closing the gates are relaxation, contentment, distractions such as TV, music, reading a book, doing an activity, moving around, doing something that redirects their focus. Of course, medications help, massage, heat, etc. Anything that can distract their focus on the pain itself. The perception of pain involves the sensory process that occurs when a stimulus for pain is present. It includes the person's interpretation of the pain. Remember, a patient's pain is what the patient says it is. Let me repeat that because it's very important. Remember, a patient's pain is what the patient says it is. Perceptions of pain differs among the individuals. The way an individual's body modulates pain is specific to that person. This is why many feel pain differently. People feel pain differently. Mediators and chemical reactions all happen differently in different people. Other factors of modulation or reaction to pain are the health of the body and the psychosocial state of that person. We can adapt to pain as well. In the case of people who live with chronic pain, they can adapt to pain so that they can continue to participate in their daily activities of life, right? Patients that live with chronic pain will tell you they live at a pain level of 5 out of 10. Yet they look at it though that they are in no pain at all because they're used to it, right? They have chronic pain. Pain sensation and relief. Pain's path begins as a message and is received by nerve endings in a burned finger. The pain signals from the burned finger travels as an electrical chemical impulse along the length of the nerve to the dorsal horn on the spinal cord and a region that runs the length of the spine and receives signals from all over the body. The message is relayed to the thalamus, a sensory center in the brain where sensations such as heat, cold, pain, and touch first become conscious. It then travels on to the cortex where the intensity and location are perceived. Pain relief begins as a signal from the brain and descends by way of the spinal cord. In the dorsal horn, chemicals such as endorphins are released to diminish the pain message from the injured finger. Please take a look at box 35-1, responses to pain. Also be sure to look at table 35-2 just below box 35-1, as this box gives specific terms to describe pain. When doing your pain assessments, this is the terminology you are looking for from your patients for assessment. Physiological responses to pain are involuntary, behavioral responses to pain are voluntary, and affective responses to pain are psychological. There must be an appreciation that each patient's response to pain is based on a host of experiences and factors, and therefore requires an individualized care plan. For example, one patient may present with a calm, objective, matter-of-fact approach to pain, while another patient may present with loud vocalizations and emphasis on their unique experience, physical movements, and demands for relief. Both patients are experiencing pain. It is particularly important to avoid stereotyping because stereotyping is not fair to your patients. Their responses to pain, because the nurse frequently encounters patients who are either in pain or anticipating that it will develop. Please remember, patients, what their pain says it is, it is. Please don't stereotype certain individuals just because, let's say, for example, you'll hear nurses say, oh, one of our repeaters or long-term visitors is back to get their, daily dose of meds. Don't become one of those nurses, okay? These patients' pains are real. And the reality is that drug-seeking patients, the likelihood that that's what really is going on is so slight. And again, as I mentioned in class, it's not our job. We don't work for the FDA. It's not our job to decipher if a patient's pain is real. If a patient says their pain, then it's real, right? Their pain is what they say it is, period. A form of pain expression that is frowned on in one culture may be desirable in another culture. For example, enduring pain stoically is a sign of strength among some groups. Other culturally related variables are family, sex, gender, and age. A person's response to pain or symptoms may be affected or influenced by the response of family members. It's important to know that, right? Religious beliefs can be a powerful influence on the person's experience of pain. In some religions, people view pain and suffering as a lack of goodness in themselves. Thus, pain and suffering are viewed as means of purification or of making up for individual and community sin. This meaning helps the person to cope with pain, thus becoming a source of strength for them. A person's environment and the presence or absence of caring supporting people around them may also influence the person's experience of pain. Because the pain experience is unique to each person, the nurse who wants to help the patient achieve comfort and pain control needs sophisticated pain assessment skills. Assessing all factors that affect the pain experience, including psychological, emotional, sociocultural, as well as physiological, are very, very important and essential. Pain is complex and difficult to interpret and requires a reliable assessment tool. This slide lists the assessment criteria for assessing a patient's pain. Remember, pain is considered the fifth vital sign. Be sure you are assessing your patient's pain frequently. Let me repeat that. Be sure you are assessing your patient's pain frequently. Generally, I will assess pain based on pain medication parameters. If a doctor has ordered pain meds every 4 hours, at the bare minimum, I am assessing my patient's pain every 4 hours. However, I will be the first one to reach out if a patient is the original orders aren't strong enough and I need to get an increase in the frequency or even the dose for my patients. Basic methods of assessment are listed here. As you can see, there are many ways to assess a patient's pain. However, be careful with the report of a family member or person close to the patient. We can use this to alert us to the assessment, but the pain must be assessed from the patient's perspective. If the patient can speak and is cognitive, they must be the one to tell you what their pain is. End-of-life patients can have pain medications ordered much more frequently, such as every hour or even every 15 minutes, as these patients will require more frequent assessments and will possibly require more pain medication. It is not unusual at end of life for patients to be in pain and anxiety. And of course, we will need to be monitoring these patients much more frequently, every 15 minutes or so. Remember, as the patient nears end of life, they become, 9 out of 10 patients become unconscious and are not able to express that they're in pain, right? So then you have to start looking for the nonverbal parameters and signs, which is the furrowing of the brow, the moaning, the fidgeting, all of those signs that tells you they're in pain. Take a look at table 35-3 for references to different pain scales. The scales I am most familiar with are the Wonker-Baker Faces scale, right? The numeric pain scale. We use these frequently at the hospital. It is widely used with people ages 3 and older, not limited to children, right? We use them all the time. I use them with patients who are unable to verbalize. Let's say they were in a car accident and they slammed their face into the steering wheel and it swelled up and they're not able to speak, right, temporarily. And so that's a great time to use the Wonker bases, Baker faces, have them point to which one, or even the number scale and tell them 0 is no pain at all, 10 the worst pain you've ever felt in your life, point to the pain, or have them write the number down, right? Self-assessment tool must be understood by the patient so they are able to choose the face that best illustrates the physical pain they are experiencing. FLAC is also a behavioral pain assessment scale used for nonverbal or preverbal patients who are unable to self-report their level of pain. Pain is assessed through observation of 5 categories, including face, legs, activity, crying, and consolability or inconsolability. Most patients with pain feel better, suffer less, and experience less anxiety when they believe that a competent nurse cares about their experience of pain and is available for help and support. Without the confidence developed in a good nurse patient relationship, nothing seems to work. I have experienced this. Patients have better outcomes and call for pain medication less frequently when they believe their nurse knows what they're doing, right? And is proactive in keeping up with managing their pain, keeping their pain under control. I have had numerous patients request pain medications from me less often because I make a plan ahead of time with, their schedule and when they're ordered the pain meds. And I make a schedule with the patient. I'm going to be in at these times to give your ordered pain meds. I have received a report from a nurse that told me that the patient was on the call light all day asking for pain medication even before the medication was available. I talk to my patients at the beginning of the shift and we go over the doctor's order for pain medication and how often it is ordered. I educate my patients on each of the medications and why they are given and what they're indicated for. We make a goal of staying ahead of the pain, which is crucial in healing and getting the patient better. And it is so much harder to chase pain that's out of control. You never ever want to let a patient's pain get out of control, which means it just gets higher and higher and higher because you never want to chase pain. You want to manage it early on and stay ahead of the pain. Always stay ahead of the pain. I always ask my patients if they want me to wake them up for their pain assessment. This way I can keep my assessments consistent with the ordered medication. Goals are generally to keep the oral form of medication controlling pain. Once the patient knows I am going to come in to assess them based on ordered medication, they no longer feel they need to set an alarm alerting them to when they have, when their pain medication is due. Setting up a trusting relationship, providing frequent assessments puts them at ease and they can relax, right? Which, as mentioned earlier, will help them heal quicker. While having the conversation with your patient, ask them about non-pharmacological methods they use at home that works. Offer or suggest some that they may not be aware of. So, for example, using a fan, um, or heat, even for some patients, right? The elderly, they get cold, so using a heat sometimes will help. Um, Music or massage therapy, definitely adding pillows helps. Positioning every 2 hours or sometimes more frequently. Aromatherapy. There's so many things that we can do that can help um, add to the pharmacological interventions we're doing. There are so many other forms of alternative pain management. Creating an environment of relaxation can help. Simple things like turning on a movie for your patients to watch, dimming the lights in the room, reducing the noise level, adding the patient's favorite music in the background, a warm shower or a warm bath. There are many things that can help reduce the patient's pain. Pharmacological pain management is a complex process that requires adequate assessment, consideration of guidelines and regulations, knowledge of the medications you're delivering, sufficient tracking and follow-up. Follow-up's huge, making sure that you go back and see, was it effective? If not, do we need to make an adjustment, as I spoke about earlier? Doing lots of patient education and interprofessional approaches. To make informed decisions and individualized care, nurses need updated information and ongoing education about drug therapy, the cornerstone of many patient treatment regimens. I joined the Pain Champion Committee when I was a new nurse on my unit. I learned a lot about pain management. We had our palliative care physician come in and speak about pain management. We learned so much that day about uh, our responsibility of being on this committee and how we were responsible to take information back to our units and to our peers about how to manage a patient's pain and to help them heal quicker. Teaching our colleagues about pain management techniques, not just pharmacological, but also those non-medical medication techniques, right? It was a great experience. Generally, our goal in an acute care setting is to return the patient back to baseline. Therefore, our goal is to control pain during the acute phase and wean them off if they did not use medications prior to admission. If they live with chronic pain, then we want to return them back to using the medications they used prior to admission. So basically, we want to get them back to whatever dosage they were on prior. If it's a chronic back pain patient and they were on 10 milligrams of hydrocodone Q 6 hours, then that's the goal we're going to shoot for when we discharge them. Generally, doctors order an oral narcotic and an IV narcotic for breakthrough pain. The idea is to control the initial severe pain with the IV medication, and then they take oral medications. They switch it up to oral for pain control. So they come in and they're in such extreme pain. And so the doctor will say, okay, let's start out with IV medications, right? Because IV medications work quicker, much quicker than PO pill medications, right? And then we'll follow up with pill medications to maintain that level of therapy. If the oral pain medication does not control the pain until the next available administration, then the IV medication is available for breakthrough pain. If you don't provide frequent ongoing assessments, then their pain can get out of control and you will need to use the IV pain medication more often. Remember, pain that gets out of control is really difficult to get under control. It puts yourself in a very tricky situation, right? Because remember, pain medication causes respiratory depression. So you don't want to get in a situation where you're having to increase pain medication to catch up on the pain threshold that's gotten out of control because we didn't take care of it in the beginning. So please don't put yourself in this situation where you're trying to get caught up on pain that's gotten out of control. We'll talk more about this in class. Adjunctive analgesics help control pain by controlling issues that can increase pain that are outside the indication of pain medication. For example, corticosteroids. This medication reduces inflammation. Inflammation can cause pain. It can also cause the originating pain to become worse. Narcotics don't have inflammation reducing properties or antidepressants. If the patient's depression is out of control, they likely will, their pain will likely be out of control as well. So it's not unusual to have multi-modalities working together, right? So they'll have an opioid, they'll have possibly a corticosteroid if their pain is inflammatory in nature. And if the patient is depressed and that's worsening the pain, then of course we'll add an antidepressant to it as well. In an effort to alleviate unnecessary pain and suffering, the World Health Organization, or WHO, devised a 3-step analgesic ladder that recommends the appropriate progression of drugs and dosages that should be used to manage chronic pain effectively. Emphasis is on individualization treatment and using the analgesic ladder to provide attentive, aggressive pain relief. Take a moment to take a look at these. The Passero opioid-induced sedation scale can be used to assess respiratory depression in adult and pediatric populations. If respiratory depression is suspected and the opioid dose is withheld, the patient may be physically stimulated by shaking or using a loud sound along with reminders every few minutes to breathe deeply. If this is ineffective, naloxone, an opioid antagonist that reverses the respiratory depressant effect of an opioid, can be used. That's one of your medications you need to know. That's on your med list. Naloxone is administered intravenously in the hospital setting, but a new nasal form may be used in other settings. As a matter of fact, they give these nasal forms out to firefighters, EMT, nurses, and we carry them with us so that if we ever come across somebody who is OD'd on illegal or even prescription drugs, we can administer this. And if you do a search on the internet, you can see several nurses that have saved patients' lives, people's lives, sorry. I always call it patients, people's lives in the environment because they've overdosed and they've administered naloxone nasally, literally saving their lives. Within 1 to 2 minutes of administering the nasal form of naloxone, the patient usually opens their eyes and is able to respond to the nurse. When the patient is alert again and the respiratory rate is greater than 9 breaths per minute, the opioid may be resumed. It has to be either 9 or above, guys, okay? Excuse me. Emphasis is on individualizing treatment and using the analgesic ladder to provide attentive, aggressive pain relief. Movement through the analgesic ladder may not always progress through all steps in an orderly manner, depending on the intensity of the patient's pain. The latter is not always appropriate, as clinicians will develop plans for each individual. This will need to be closely monitored and assessed for changes along the way as well. PCAs, or patient-controlled analgesic pumps, is a computerized machine that gives you a drug for pain when you press a button. In most cases, PCA pumps supply opioid pain-controlling drugs such as morphine, fentanyl, hydromorphone. These medications may be delivered either continuously, basal rate, or only when you press the button, a bolus. Pump will not give the patient the drug if it is not time yet. So with the bolus button pushes, when they push the button to get a bolus, let's say it's programmed to be given every 15 minutes if the patient needs it. So if they press the button, they get 1 dose. But then if they press that button again anytime within that 15 minutes, it'll only deliver the original dose. It will not give extra doses, right? Remember, no one should press the button on the PCA pump except for the patient themselves. This includes the nurse. These pumps are used sometimes after surgery or for patients at end of life and can be a more effective method of pain control. Pain still needs to be assessed every 4 hours, and if the pain is still uncontrolled, contact the doctor to get the order adjusted. Epidural analgesia is the most popular method of pain relief during labor. Epidural analgesia is regional anesthesia that blocks pain in a particular region of the body. The goal of an epidural is to provide analgesia or pain relief rather than anesthesia, which leads to a total lack of feeling. Epidurals block the nerve impulses from the lower spinal segments. This results in decreased sensation in the lower half of the body. A small tuber catheter is threaded through the needle into the epidural space. The needle is then carefully removed, leaving the catheter in place to provide medication either through periodic injections or by continuous infusion. The catheter is taped to the back to prevent it from slipping out. Local anesthesia is used to numb the feelings of a specific part of the body. This prevents pain during surgical procedures. An anesthetic drug is applied to the part of the body that is to undergo surgery. It may be used with sedation, which calms the patient and reduces stress levels. Together, they enable the surgeon to carry out the procedure without pain or distress. Local anesthesia only lasts a short time, so it is mainly used for minor outpatient procedures where the patient can leave on the same day, although they will need a driver to drive them home. Local anesthesia is used when surgery is minor and does not require general or regional anesthesia, when the procedure can be done quickly and the patient does not need to stay overnight. The operation does not need the muscles to be relaxed or for the patient to be unconscious. Examples include dental surgery, the removal of a verruca, a mole, cataract, biopsies, etc. This is the end of the chapter.